Welcome to session number 13. Angela is lucky 13 today of achieving your optimal health. And today's webinar is Dr. Angela Carlson as presenter. And her title is Which Lab Tests Are Essential for Optimal Health? And once again, to get to these webinars, you would go to Las Vegas Area Trails, where we're placing all our webinars. And you can see here we've got all the sessions in this series, Achieving Your Optimal Health. And the idea is that people can come to these webinars. They can learn from the professionals. They can ask questions. They can connect with the professionals. And the professionals can support each other in achieving our optimal health. Set a health goal. It's not just about information, but it's about transforming your health and improving your health. So look at some of these titles that we've got. I'm just going to pick a few. Angela's last one, what is your optimal diet? Packed with nutrition information, and you're really going to see your nutrition, your diet differently after looking at this webinar. And then we've got energy medicine and energy healing by Holly McClanahan, and overcoming the impact of childhood trauma through hypnotherapy by Loya Riggin, and affording medical care along the way to achieving your health goals, Sherry Martin. Alternate ways to deal with chronic pain, Dr. Denise Tropia. Fascia, what role does it play in your health, with Gus Vargas. And each of these presentations are very powerful, and they've changed the way I look at my health personally. And I have been always devoted to being in top health and pushing my body to the limits. And I thought over the past 64 years that I amassed just about all the information I needed. And I got to say that by being in these webinars and experiencing the professional expertise of each of our presenters, I feel like I've advanced personally light years beyond where I was when we started. So anyway, today is a very special webinar with Dr. Angela Carlson. And when you get to the health education link, just click on which lab tests are essential for optimal health. And we go to Dr. Angela Carlson's page, and you'll see after an introduction, you'll learn a little more about Dr. Carlson, and then we will post the webinar slides, webinar notes following the presentation, and then up in this portion, we will post the webinar replay video, and we do that with every single webinar. So there is a library of valuable health content here through this webinar series. And today I just want to focus on introducing Angela Carlson. She is a board certified naturopathic doctor, and licensed. ND is what they go by. And this is a person that has had a lot of education and experience, a holistic health, person dedicated to finding natural ways to attain your optimal health, which means getting away from prescriptions and synthetic drugs, and going at the cause of what ails us rather than just treating symptoms. All these things Angela stands for, and she'll definitely share more with you. But I'd just like to share a little bit about lab tests. This really opened my eyes. I went to the American Clinical Laboratory Association site just this last week as I was thinking about how to introduce Dr. Carlson. And very interesting that these lab tests are really what doctors use um, to diagnose what's going on with us. And you've probably been to a doctor and they've said, oh, take this lab test. And we say, okay, I'm going to take it. You don't really know what it's about. And maybe you don't really get a full evaluation of this test, but just know that here's a quote from the American Clinical Laboratory Association: from early detection and diagnosis of disease to individualized treatment plans based on a person's unique genetic makeup, clinical lab test is key to improving healthcare quality and containing long-term health costs. And the value of lab tests, they can catch critical changes in your body before they manifest as heart disease, cancer, diabetes, or worse. Lab tests result in, they guide 70% of medical decision making, and yet they remain remarkably cost efficient for patients and healthcare providers alike. So in this webinar, Angela is going to help us to shed some light on what these lab tests are about, and to understand why does the doctor suggest certain lab tests, and are there lab tests that we need to know about and participate in our health rather than giving it over to the medical establishment. And Angela's all for participating in your health and maintaining ownership and not giving your health away to some external authority. And so with that, I'm going to introduce Dr. Carlson, and I'm going to stop sharing my screen. You go ahead and take the screen share and enlighten us.
Okay, everybody can see everything okay?
I can see it great.
Excellent. Well, thank you so much, David, for that great introduction and for some helpful statistics and just your eagerness to get involved in this, what seems to be kind of a dry topic, but I actually think it can be pretty exciting when we look at it from a certain perspective. And also, I just really want to say thank you to everybody for logging on to this webinar tonight and for continuously supporting me and supporting this. I think that when you're the presenter, it has meaning, and it has meaning all the time participating. But I'm very grateful, and I just want you all to know that I appreciate that. So so tonight I'm going to talk about which lab tests are essential for optimal health. Hopefully by the end of this topic, at this talk today, everyone will have a little bit of an idea, and we will all have a resource to refer back to for what labs should we be asking for or doing on a regular basis. So today we are going to discuss the following. We're going to understand the difference between normal and optimal when it comes to lab values. I will provide you information on what labs I believe to be essential to your annual health assessment, how often should we have lab work, and most importantly, how do we use this blood work for prevention of chronic disease and to develop a strategy for optimal health, not simply just to diagnose a disease or condition. And then we'll end with some very simple tips on how to get the most accurate results when you do go for your blood draw. So as David was saying, I really think it's important that we are our own health advocate. So this presentation is really designed to be a resource for all of us to share and refer back to. Some of the information may be a little bit boring, it may be a little techy. I tried to keep it pretty simple, but the intention is for this to be something where if you have somebody that's wondering what labs they should do, they can look back on this. If you have had labs done and you want to kind of check and see if there isn't something that should have been run, etc. So it was really my intention to make this something that we can all refer back to. just remember, it's really important to be our own health advocate. I can't express that enough at how there's just so many shortcomings currently in the medical system on how we manage care. We're all pretty familiar, especially in this group here, that the medical system as a whole is really designed to diagnose disease. It's not designed for prevention. So most primary care physicians are ordering the minimal amount of tests, and they're often using markers that are not adequate at detecting early imbalances. A lot of times patients will come to me and they're misinformed by their primary care doctor or another physician, and they're told that their labs are normal and that they're healthy, when actually either all the tests that I feel should be done have not been done, or there are actual abnormal ranges, or the finding is in a reference range that is not optimal and it's still considered normal. And we'll talk a little bit more about that. So this right here is just a list. This is a slide, if you're coming back to this presentation, that you can just refer to this slide. This is just a list of basically all the labs that I'm going to touch on. So I'm not going to read this, but this was just something convenient so that you didn't have to skip slide to slide if you do choose to use this resource. So first I wanted to just start by talking a little bit more about the concept of normal versus optimal when we talk about reference ranges. It's really important to understand that the reference range that's given on a lab test is determined by the people that go and get that test. So we'll use thyroid, for example. TSH is a great example of this. The TSH reference range has been established by all of these people that have gone to the lab that probably have an unhealthy thyroid. So and then they take an average of the people that go to the lab. So given the fact that we do not have a medical system where healthy people are going and get the lab done, you can see how the reference range is going to be skewed towards an average of unhealthy people. So with routine blood testing, we really want to focus on optimal, not on average. So it's really important. I'm going to say this probably 10 times. Always remember that normal does not mean healthy when it comes to your lab assessment. So this is really one of those things where it's really important to work with a doctor or educate yourself. And I mean, it's challenging. Like, I don't even have all the optimal reference ranges. There's not exactly a book that has them all in it. I mean, there's various people, there's various resources. A lot of us get what we feel to be an optimal reference range based on our clinic population, like the people that come in and what you see and what are trends. So some of this is sort of developed in practice, but it's really important just to be self-educated. And if any with your doctors, that you really know that optimal and normal are different. So we're just going to kind of go through these. I realize that those people that are on here may or may not be a clinician. The intention is not to give you, like a lab physiology test or anything, but it's just, I think it's good to have something to look back on where you could be like, wait a second, so I had my blood work done and I had, my RDW is a little high. Like, what's that even mean? And some of that stuff will be on here and some of it isn't. But basically, a CBC is a really common test. Here's a list of all of the different things that it contains. Red blood cells and white blood cells. It tells us about hemoglobin and hematocrit, the size of our cells, and then a breakdown, the neutrophils, the lymphocytes, the monocytes, the eosinophils, and the basophils. Those are all different kinds of white blood cells. So basically, this test is used to detect infection, which is why it's done routinely all the time, anemia, whether that's iron deficiency anemia or a B12 or folate anemia, other types of nutritional deficiencies, and then also cancer. And many other things. I mean, to some degree, I'm oversimplifying, right? There's lots and lots of different ways to use these tests. This is just kind of the general idea. A metabolic panel or a comprehensive metabolic panel, sometimes we'll call it a CMP. This is the test that's going to look at your blood sugar, uric acid, kidney function, your electrolytes, several protein markers, bilirubin, which has to do with the gallbladder and the liver, ALK Phos, LDH, our liver enzymes, and a GGT. So this test is used to evaluate blood sugar levels. That's really important when we're looking at prediabetes or diabetes or generalized cardiovascular risk. If we are evaluating kidney function, and kidney function is important in so many things: blood pressure, maintaining our body pH, and filtering nutrients and waste products from our blood. Liver function and inflammation, especially with medications. I put this little, the picture of the liver here on the side. We live in a society where lots of people are on lots of medications. So one way that this particular test is used is to check your liver enzymes and make sure that everything is okay. And then the electrolytes. Electrolytes are really complicated. Just every single cell in the body has an electrical charge. So muscle contractions, including the heart, nerve impulses, fluid balance. So many things. So this is a real standard test that pretty much all doctors are doing. Okay, so now we're going to get a little bit more into the nuts and the bolts of where a naturopathic functional medicine approach and a standard of care approach might be very different. So we're going to spend quite a bit of time talking about blood sugar. I think this is really important. These are the tests that I'm going to briefly discuss. Just a fasting blood sugar, that's a component of the metabolic panel. You can also just have a fasting blood sugar on its own. Hemoglobin A1C, an oral glucose tolerance test, something called fructosamine, which is not used as often, and then lastly, the post-meal blood sugar. So starting with fasting blood sugar, most of us are pretty familiar with this test. And what this test is doing is measuring the concentration of glucose or blood sugar, either one, those are interchangeable, after an 8 or 12-hour fast. It's really important to know that this only provides information about your blood sugar in a fasting state. It doesn't tell you anything about how your blood sugar is going to respond to the food that you eat. And that's a really important distinction because we are people that eat food, so it's important for us to get information that correlates with how we live physiologically, with natural physiology. So this is the most common but least sensitive marker to evaluate blood sugar. Next, we have hemoglobin A1C. So hemoglobin A1C reflects the average blood sugar over the past 2 to 3 months. And this is based on the theory that a red blood cell lives about 3 months. So if we measure the amount of sugar that sticks to the cells, then we can get an idea of how much sugar has been in the blood over the previous 3 months. Because sugar sticks to things. So a red blood cell lives for 3 months. Sugar sticks to red blood cells. Therefore, we can get an average of what the blood sugar has been for the life of that red blood cell. The problem is that there's a lot of variation in the life of a blood cell. So the number is reported as a percentage of hemoglobin that has become glycated or stuck to that sugar. So this test assumes that everybody's blood cells live for 3 months, but there's some really common conditions that cause changes in the lifespan of a red blood cell. So if you have normal blood sugars, then you could possibly have a false elevated hemoglobin A1C because your red blood cells are living longer than average. If you have higher blood sugars, then your blood cells are going to tend to not live as long, and you might have a falsely low hemoglobin A1C. Also, hemoglobin A1C is impacted by anemia, which is a very common condition, dehydration, which is also very common, and pregnancy. So we can quickly see that there are multiple different things making this test not the greatest thing to be relying on. It's useful. I'm not trying to say that it's not useful, and I do it on all my people, but it's not something that we should be hanging our hat on as far as a diagnosis of diabetes or not prediabetes. So we all know, especially Dr. Tropia being the podiatrist in the group, and I know, multiple other hats that she wears, but we have an epidemic of diabetes. And I think there's multitude of reasons, but in the context of this talk today, I really feel like because we're using fasting blood sugar and hemoglobin A1C as the primary tests that are being done in the primary care setting, we're missing so many things for so many reasons. So those are both the least sensitive markers for predicting the future of diabetes and heart disease. Yet they are the most commonly done tests in the primary care setting. I know it's kind of like, duh, you feel a little just, I mean, it's just silly. So oral glucose tolerance testing, this test is a little different. So what this is going to do is it's going to measure your insulin response to glucose. And insulin is made by the pancreas to help move sugar when we eat food, the sugar to get from our bloodstream inside the cell. So the way that this test is done is you fast and then drink 75 grams of glucose dissolved in water. Then at the lab, your blood sugar is tested 1 and 2 hours after. So this is definitely helpful in the sense that it's going to provide more information about how your blood sugar is responding to glucose. I think that's supposed to say to insulin, how your blood sugar is responding to insulin. In other words, how your blood sugar is responding to food. The problem is that this is not realistic. We don't drink 75 grams of pure glucose. It's just not, again, that's just not how things happen in the natural environment. And for some, this can cause dangerous and uncomfortable spikes in blood sugar. And you can see the pictures on the right. We've got the woman that is, struggling with urinary frequency, and then another woman is struggling with fatigue. These are symptoms that can really become difficult when we give somebody 70 grams of glucose to evaluate their blood sugar. It's not the greatest test, but it does have some value. Here is where I am showing you a little bit between normal and optimal. So this is really, really remarkable. So I'm going to take just a second. So if we're talking about fasting blood sugar, an optimal value is under 83. Normal, according to the lab, is anything under 99. And pre-diabetic is 100 to 125, and actual diabetic is 126. So with hemoglobin A1C, an optimal is considered 4.6 to 5.3, but the conventional labs are saying we're not going to do anything until it's up to 6. So studies show that using the American Diabetes Association criteria of an A1C of 6 as being normal, meaning we're not going to do any intervention and we're going to dialogue to the patient and say, you're good, you're fine. You're missing 70% of the people with diabetes and 82 to 94% of the people with prediabetes. That is an epic failure in the medical system right now. And so then we'll talk a little bit more about the glucose tolerance test. I think I talk about that again later, but basically with that one, optimal is basically you don't want your blood sugar to maintain very high levels over 140, but that's getting kind of a little bit out of the scope of this, so I didn't really want to give a lot of detail there. Fructosamine is not, it's not as commonly used. It's definitely better than hemoglobin A1C because it measures the blood sugar concentrations over a couple of week period. So it's not going to be as reliant on the lifespan of a red blood cell. And it doesn't have those false readings with anemia or pregnancy. So this would be a good option. I actually would like to start using this test quite a bit more often. Post-meal blood sugar is definitely what I would advocate to be the best way to get information as opposed to the oral glucose tolerance test. Because what you do is, you perform this at home, you can get an inexpensive glucometer, and then the blood sugars are collected at specific times after meals for 3 days. There's a protocol that I follow and others follow in our practice to where we're getting really good information based on what your blood sugar is doing 1 and 2 hours after eating a certain amount of carbohydrates. We're analyzing that data to determine how your glucose and insulin respond to the food you eat. So it's much more masking what's actually happening in real life. So I believe this to be the most reliable and accurate way to predict future diabetic complications and heart disease. The whole intent here is to have a system in place to prevent a diagnosis of prediabetes or diabetes. So that's why I really think this is important. It's as far as the post-meal blood sugar, it's really important to know how many hours a day are your blood sugars elevated over levels that are known to cause complications. So if we just do a fasting blood sugar and it's elevated, we don't really know if it's just elevated at that moment. Has it been elevated for, days, weeks, hours? So when we're doing the testing at home, we're getting a lot more information about how long are the blood sugar levels at a known range where we know cause damage to the kidneys or damage to the eyes, etc. So that's where it really becomes a lot more helpful information. Okay, so insulin. Insulin is a really, really important test to evaluate. Honestly, it's hardly ever done in the conventional setting most of the time. But this test is used to evaluate insulin resistance or prediabetes. And the higher your levels are, the closer you are to developing diabetes. Again, insulin is made by the pancreas, and it works to keep your blood sugar levels even. And, most of us know that a diet high in refined carbohydrates from things like bread, pasta, rice, and potatoes, that basically is requiring your pancreas to make lots more insulin in order to maintain normal blood sugar. So routinely testing insulin can determine high levels of insulin years or decades before diabetes develops. Often insulin changes before fasting blood sugar. So again, if we're relying mostly on hemoglobin A1C and fasting blood sugar in a primary care setting to evaluate blood sugar, we're missing where there's all sorts of changes that go on beforehand, such as changes in insulin that give us warning signs before the blood sugar and the hemoglobin A1C are really going to reflect the problem. Okay, so we're going to move on. We're going to move on from blood sugar. So I'm inclined to ask if there's any questions, but I don't want to get derailed. So I guess if you have questions about blood sugar, maybe write them down, and then when we're done, I'll do my best to try to answer them, and that way I know I've got enough time to kind of cover the other things. Cool. So the next thing that I wanted to talk about is iron. And man, let me tell you, iron is coming up in my male population a lot. So I'm just going to put it out there, so if anyone listens to this in the future, it's really important to test for iron in both men and women. So evaluation of iron deficiency and iron overload is recommended in all patients. So here's the list of the tests that it involves. Something called an iron panel that has serum iron, iron binding capacity, and then something called transferrin saturation, as well as ferritin. That's kind of what I would call an iron evaluation. So serum iron, anytime we say serum, that basically means, what's in your bloodstream at that time. And again, this is the most common marker ordered by clinicians, and it's the least reliable. The levels are affected by alcohol, by common drugs, birth control pills, methotrexate, testosterone, aspirin, metformin, sleep deprivation and stress. So those are all pretty common things, that impact the results of that test. Also, what you ate the night before. This is something that's going to go up and down based on diet. So again, it's a useful test that I run, but I don't tell someone about their iron status just based on a serum iron. That's not adequate information. Ferritin is the storage form of iron, and this is the most sensitive marker for iron deficiency. And this is a really helpful lab. And it is important to know that ferritin can be affected by inflammation. So if somebody has a lot of inflammation and they have elevated ferritin, it doesn't necessarily mean that they have too much iron. It can mean that, but oftentimes ferritin will be an inflammatory marker that can kind of come and go. So there is a little bit of variation that it's important to know with ferritin. So iron deficiency, this is another just kind of like little note of education. Iron deficiency, it can occur without anemia, which is actually more common. So if we look at this little table right here, we see that we have 3 stages of iron deficiency, and anemia is the 3rd stage. So when doctors are testing for anemia, they are already evaluating at stage 3. If we are testing for an iron deficiency, a functional deficiency that can be corrected so someone does not develop anemia, that's how we're using an iron panel, because changes in ferritin, as you can see in stage 1, ferritin is going to go down before iron goes down. So it's important to include ferritin in our screening blood work so that we don't wait until somebody has changes in the CBC, because once there's changes in the CBC, they've been iron deficient for a long time and they've been having symptoms associated with that. So we can avoid all of that by ordering more comprehensive tests. So most primary care doctors are looking at the CBC to evaluate for iron deficiency anemia and do not routinely order an iron panel or ferritin. So by ordering that iron panel and the ferritin, iron deficiency could potentially be prevented. Iron overload. This week, I've had 2 men in my practice with various degrees of iron overload. So there's a difference between, so hemochromatosis is a condition, it's a genetic condition that causes iron overload, but you can have iron overload and not necessarily have what is defined as hemochromatosis. So it's really important in men to also have your iron checked. You wouldn't think of that, but the reason that you want to do that is because iron, if you've got the right genetics, which is not all that uncommon, then you don't eliminate iron and your body holds on to it. And it contributes to diabetes. It contributes to gout. It contributes to high blood pressure, cardiovascular disease, diabetes, Alzheimer's, dementia, all the things that are the most common chronic diseases right now. So the treatment's very simple. You basically, it's phlebotomy. You donate blood. But the problem is that we're missing it. So this is kind of complicated. I think that the take home here is that iron overload, you don't have to have actual hemochromatosis to have iron overload. And it's a spectrum, kind of like insulin resistance or celiac disease and gluten sensitivity, where some people have celiac disease, some people have a gluten sensitivity, and it's a spectrum in between. It's the same thing with iron. Some people have hemochromatosis and they have really significant iron overload, and other times people are only going to have some manifestations of the iron overload, but it's still a problem and should be evaluated. All these things here I listed on the bottom are associated with iron. I mean, iron rusts things, right? So it's kind of straightforward to kind of acknowledge all the problems that we have with too much iron. So cholesterol and lipids. So a lipid panel, of course, is part of all screening blood work. Most of us know, what's in a lipid panel. There is another marker that I think is really important to do, and it's called either ApoB or LDLP. They're the same thing, and that is a measurement of the number of LDL particles that are carrying the LDL cholesterol. And the LDL particle number is thought to more adequately correlate to cardiovascular risk. So if we look at this little picture on the side, we see that there are 4 people that all of them have the same LDL cholesterol, right? Every single one of them has the same LDL cholesterol on the lipid panel of 125. You can see, though, that Maria has a higher risk than Jerry because her cholesterol, her LDL cholesterol, is being carried in more particles. So you can have the same amount of LDL cholesterol, but have a smaller number of particles or a higher number of particles. And when you have a higher number of particles, you have more potential impact in the blood vessel. Just imagine there's all these small little dense particles cruising down the blood vessel, and they have the ability to knock on the walls and cause inflammation. So it is definitely important to evaluate the LDL particle number when we are looking at lipids. Inflammation, I think that conventional doctors are probably finally on board with this. It seems like we have more cohesive information about inflammation being a root cause of disease. So HSCRP is a really common test. That's a pretty standard test that pretty much all doctors do, but they're not always doing homocysteine. So homocysteine is important because it's also a cardiovascular inflammatory marker, and it's also used to indirectly evaluate the B vitamins, B6, B12, and folate. They don't measure it directly, but you can get some indirect information, and that's important. All right, so thyroid. This is another big topic. So these are all the tests that I do on a new client when I'm evaluating their thyroid. I want to make sure that everybody knows that even though that little blood tube says thyroid panel, there's not really a standardized thyroid panel. Thyroid panel basically means whatever the doctor that you're seeing decided he wanted his thyroid panel to be. So don't just say, I want a thyroid panel, because that's not quite how it works. You really want to know the specific tests and then make sure that they're doing those. And so these are a list of all of the tests. So TSH, total T4 and total T3, free T4, free T3, reverse T3, and then thyroid antibodies. So many primary care doctors only test the TSH, which is the most sensitive marker to evaluate for hypo or hyperthyroidism, but you cannot rule out problems with the thyroid based on TSH alone. And this is also really important, again, to know that normal reference ranges do not mean normal or optimal. This is especially true with the thyroid. So just real briefly here, total T4 and total T3 is basically giving you an idea of how much thyroid hormone is being made by the thyroid gland. The main thing with these, the limitation here is that it's bound to a protein. So it's not the actual hormone that's doing the work in the body. It does help us know how well the thyroid is making hormone, but we really need to have the T3 and the T4, the free T3 and free T4, to know what's the metabolically active thyroid hormone. So all of these are important to really give a comprehensive picture of how our thyroid is doing. And if your doctor's not doing all of them, then they don't all have to be done all the time, but I just really want to avoid anybody being told that something is healthy or optimal when the proper information and the proper in an optimal reference range hasn't been looked at. Thyroid antibodies. So this is really important. Thyroid antibodies, the most common ones that are involved with hypothyroidism are called TPO, or thyroid peroxidase antibodies. The other one is called anti-TG, or thyroglobulin. And these are used to evaluate Hashimoto's thyroiditis, which is the most common cause of hypothyroidism. And Hashimoto's is an autoimmune condition where the body is attacking the thyroid gland. And as I said, it's the most common cause of low thyroid function, so it's really important to evaluate this. The antibodies are rarely tested by conventional doctors because it doesn't change their treatment. So their treatment is going to be thyroid hormone replacement, basically, regardless of what the underlying cause is. And I also routinely recommend thyroid medication, but we're also looking for the antibodies so that we can then be addressing the underlying cause of why there is the autoimmune attack to the thyroid. So this is a place where I'd like to just talk about, the difference primarily between a naturopathic functional medicine practitioner like myself and a conventional medical doctor, at least conventional medical doctors that are not using this kind of thought process. I mean, there's all different kinds of doctors that do different kinds of things. So I'm just speaking to somebody that's simply using medications to treat symptoms, not someone that's really taking the time to try to understand some of the underlying root causes. So that's really what I do in my practice, is I am really being a detective to try to understand and address the root cause of a problem. I'm not simply interested in suppressing symptoms. And hypothyroidism is a really important place to talk about this, because hypothyroidism is most of the time not so much about the thyroid gland. It's more about the immune system. So that's why I'm going to be testing thyroid antibodies in every single one of my patients, especially at their first visit, and making sure that we're having a big conversation about what are the underlying causes to the problem and not just addressing the symptoms. Because then when we address the underlying causes and we give the body what it needs, it will naturally be able to heal itself. And we won't even have to be doing as much, including supplements, including all the things. So again, I'm going to say it one more time. Normal does not mean optimal when it comes to thyroid labs. Many people have normal labs, but do not have optimal thyroid function. All right, getting to the end here. So this slide is about vitamins and minerals. Vitamin D is pretty standard these days. I think it's a good idea to have vitamin D checked once a year, and sometimes maybe even twice a year, but once a year for sure. B12 is another really important thing. Serum B12, again, is going to measure the amount of B12 in your bloodstream at the time of the blood draw. It's going to have the same fluctuations like serum iron, etc. So it's very variable. It's influenced by a lot of common conditions, and it tends to decline late in deficiency. So again, we've got another situation where the only test that we're doing is the one that shows up where we've had the deficiency long enough to where now it's associated with more pathology and not prevention. Methylmalonic acid is much more useful to detect fluctuations, much more useful. It has less fluctuations than serum B12. So I think that's a really helpful test for B12 status. And then with folate, again, I'm not a big fan of serum folate, and I really prefer what's called RBC folate. That's going to be the folate that's actually getting in the cell to do the work. And that's a much better diagnostic tool than serum folate. Uh-oh, now my computer's not working. There we go. So magnesium, I think magnesium this is the last test. This is a really important test. And I feel like I'm repeating myself, but at least you'll remember it. Serum magnesium does not correlate with tissue levels. You know, only a small amount of our total magnesium is located in our bloodstream. So we're just not really getting a very good look at our magnesium levels when we're measuring it in our blood. So if you have a doctor that has ordered magnesium for you, if it doesn't say RBC in front of it, it doesn't tell you anything. So make sure you're getting the right tests for the right information. So RBC magnesium is going to measure the magnesium inside the red blood cells. And this is a much more accurate marker for magnesium. So how often should we get labs? And so I think that if we're using lab work for prevention, it's really a good idea to get your labs done 1 to 2 times a year. And then if maybe there might be smaller things that you're following up on in between those 2 times. It's also really important to get a baseline when you're healthy. You know, it's kind of like our finances, you know, or our vehicles. We want to get our oil changed, you know, however often we need it, or we want to get our vehicle serviced, you know, once a year. We don't wait until the car is broken down on the side of the road to then do some kind of repair. You know, we have these maintenance systems in place. So a really good idea, regardless of where you are, if you're healthy, if you're perfect, get your blood work done 1 or 2 times a year so that you have all of the markers, and then you can start to track subtle changes, and then you can intervene and act sooner rather than waiting until something is in a pathological state, and it's a lot harder to improve it at that point in time. So a lot of people wait until it's too late to start monitoring their health, or they rely on their PCP recommendations, which are often inadequate. All right. Lastly is I found this really helpful when I was reviewing this. So here are some thoughts about how to get the most accurate results when you do go for your blood work. One would be, continue your normal life. Don't all of a sudden be like, oh gosh, I have to get my blood work done, so now I'm going to go to kickboxing. Do your normal life, your normal thing. Don't start something new right before your blood draw. Eat your normal diet that you've been eating. Avoid getting blood work done like right after a vacation or right after a holiday. Wait until you're in kind of like your normal routine before doing your labs. You really want to try to avoid having your blood work done when you're sick, unless you need to find out why you're sick, obviously. So what I mean by that is if you're doing, screening labs, if it's like your annual labs, you don't want to necessarily do it when you have the flu. You want to wait till you're feeling good so that it's reflecting kind of the rest of the time, not so much when you're ill. You want to fast properly, drink plenty of water. 9 times out of 10, blood work is fasting. So you want to make sure you've gone without food for a minimum of 8 hours and that you have drank water. That's definitely important. You don't want to do rigorous exercise the day before your blood draw. Avoid having a blood draw if you had a really, really bad night sleeping. Now if you just have problems with your sleep in general, obviously you just need to get your labs done. But if you overall sleep okay, and then you have kind of a spell of something's going on where you're having really bad insomnia, just wait until it gets better. With thyroid tests, it's best to take your medication after the blood draw. And also, this is something that people miss because biotin, I think, can be in a B complex, and sometimes people are just taking biotin. You want to avoid biotin for 48 hours prior to having your thyroid labs done. Drink plenty of water the few days prior to your test. Avoid alcohol the day before, and try your best to have your labs done with the same company each year. If you've been having them done with LabCorp, do them with LabCorp. If you've been having them done with Quest, do them with Quest. So that way you're comparing. It's okay if not, but if we're talking about most accurate and doing, the best that we can, it's more ideal to try to use the same company since they do have different reference ranges and they might be slightly different. So that's definitely helpful. So I believe that's the end of my presentation. So here's my contact information, my website, and my phone number if anybody wants to reach out. And I definitely encourage people. I'm looking forward to putting this on my website because, this is something that people might refer back to at some point in time. And of course, anybody else can use it. So thank you for listening. I'm available for any questions or anything else that David or anyone else thinks.
Okay, I've got a question.
Okay.
Could you just scroll back up on your presentation and give us an example of how one of these lab tests might influence your decisions as far as treatment, how they might guide your treatment?
Okay. So I'm going to go to insulin. So if somebody comes to me and they have elevated insulin levels, then I'm going to be talking to them a lot about decreasing carbohydrates in their diet, putting them on a diet. Most of you at this point in time know that I'm more on the paleo side of things, but I'm going to be talking to them about decreasing carbohydrates, increasing high quality proteins. I possibly would be, and also exercise, activity. I'm trying to use the word activity more now than exercise because really we just need to move our bodies. We don't necessarily have to go to the gym. We just need to move around. We just need to not sit all day long. And so I look at the insulin, that would help tell me about how aggressive I need to be with them with certain carbohydrates in their diet. With iron, if somebody has iron deficiency, then we're going to be talking about foods that are higher in iron and making sure that we're addressing that. And also, anytime that you have an abnormality in a lab, you want to try to figure out why. So this guides the conversation into, okay, does a woman have iron deficiency because she's having heavy menstrual cycles, or is she a vegan or a vegetarian and not getting enough iron in that way? So those are ways that it helps us with the diet kind of side of things. If there is, problems with cholesterol, cholesterol or LDL particles, this one is a little more challenging because I need to know more information. Like I evaluate their blood pressure, their blood sugar, there was something I was going to say, but I often think that we focus a little too much just on cholesterol. So I oftentimes like to know all their other cardiovascular risk. Certainly with the nutrients, the vitamins and the minerals, we want to make sure that if someone is B12 deficient or if somebody is magnesium deficient, we want to make sure that they're getting all of that in their diet. So that really helps us with the diet side of things. Blood sugars helps us with diet. Mostly everything is activity, and that's kind of like a good place to get started.
Okay,
I have a question with the LDL because that's genetically predisposed, isn't it?
Are you asking, is LDL genetic?
Mm-hmm.
I definitely
Different
think
particles.
Oh, yes. The LDL particles definitely has a huge genetic component to it, for sure.
Yeah, so that's going to be a different way we're going to look at the inflammation and how someone is inflammation versus not, and what their needs are, and look at that CRP and homocysteine. Is that correct?
Yes, absolutely. You got it right. Yeah, there's the LDL, the lipid markers, whether it's the cholesterol panel LDL or it's LDL particles. I do not base recommendations solely on those. I like to get more of a comprehensive picture about what you just said, about inflammation, about blood, all the cardiovascular risks, for sure. Yeah. Other questions?
Yeah. Sorry. Go ahead.
Gus. What is it, Gus?
Okay.
So I might have missed this part, but when a new patient comes to see you, is the healthy blood test being run, the comprehensive, where we're looking optimal health, or are we doing the, depending on what their reason for being to see you, or are there more strategic and more targeted tests being done?
So I think if I'm understanding the question correctly, you're saying if it's a new patient and they're pretty healthy, what would I be doing? Or what's a new client? What blood work look like in general?
Okay. Yes. That would be a better question. Yes.
Yeah. Well, so this page right here has all of the things that I'm considering, and I don't necessarily run every single one of these on every single person, but I have a conversation in my mind or with the patient about each one of them. Maybe they've had them done recently. Maybe they have had enough history in the past where I'm like, okay, I don't think I need to have that one this time. Maybe they don't fit exactly a particular picture, but I do probably 95% of the tests on this page with my new patients, pretty much. Yeah. And after writing this talk, I'm going to be even a stronger advocate for this, because I'm even more convinced after doing this of the importance of these labs in prevention, and it was really valuable to me to kind of get re-inspired to be like, oh, we're using these for prevention. We're using these so that you have the data, it's like, I don't know a whole lot about finance, but I'm assuming that we look for trends, right? We look at things in the past and we're anticipating things in the future. And if we don't have enough data points, then we can't really make good decisions. So I think that that's a really good thing to consider if you haven't done blood work in a while, or if you're like, oh, I'm fine, I don't have any problems, if and or when you do develop a problem, we'll be able to handle it much easier if we've got some back information on things.
And also, you talked about how the hemoglobin A1C can be fairly unreliable because of those guidelines. Like we see the guidelines of, in that gray zone, are you pre-diabetic or not? But if they have all the makeup for metabolic syndrome, then we know that, you know what, let's just treat it like you are pre-diabetic and go with that.
Absolutely. You bring up a really good point, and that point is that we treat people. We don't treat labs above all, right? So that's another really important thing. Thank you for saying that. This is all just to help us stay informed and to track progress and to continue to have data and a good conversation. But absolutely, the presentation of how somebody presents, their family history, their past medical history, all of that is equally, if not more important than a blood test.
Yeah, because people get so, you get hooked on, oh, my hemoglobin A1C was only 5.6. Oh, I'm good. Well, not necessarily. You're 40 pounds overweight, et cetera, et cetera, et cetera. So, yeah, you're right. We have to go with the whole picture.
Absolutely. Thank you well said. I appreciate it.
And what I like about taking an optimal snapshot, this data point when the person is feeling better, is you get the conversation about health started preventively, right? As opposed to, hey, I'm sick, let me go see, naturopath, right?
Yeah. I mean, I think that it's, slowly, like one conversation at a time, we're trying to shift the paradigm that we have a sick care system and not a health care system, and a lot of people don't get lab work. They think that it's going to be really expensive. By the way, I'll just throw this out there that if you paid cash for for the majority of these tests, I'd say it's a $300-ish. Like we're not talking about thousands and thousands of dollars, so I feel like it's a very reasonable investment to get this kind of data for ourselves. Yeah.
Now, I noticed in your presentation, I was, as far as treatment, I was waiting for you to say if there's like a magnesium deficiency, we need to give you magnesium pills, or if there's an iron deficiency, we need to give you an iron supplement. I didn't hear you say any of that. The few times you responded, it was more like we need to do something with your diet. Did I catch something there? And do you want to speak to that?
Yeah, I think that when you are a holistic practitioner, you are taking a step back and not evaluating every single sign. A sign would be a lab finding or something you found in a physical exam. A symptom would be something that the person's telling you, rather that, like, we have a system that's very much, here's a sign or symptom, here is a medication, or here's a supplement. Here's a sign or a symptom, here's a medication or a symptom, right? That's called palliative care. That's like palliation. It makes us feel better. And that's a legitimate thing, and that's important. But in my practice, I try to do as little palliation as I need to. And what I'm really mostly after is taking a step back, trying to understand the physiology, and then do the things that naturally support the physiology and also support the patient into removing various obstacles to cure, so that the body can do what it needs to do on its own. So it's like, yes, for some people, I'm going to give magnesium when they have a magnesium deficiency. If they have iron, I'm going to give them iron if necessary. But what I'm really interested in is what is the underlying cause to these imbalances, and how can we address that much more effectively, because that is ultimately going to be cure. It's not going to be palliative. So there's always this give and take between palliation and cure and root cause. So that's why it's a little hard to talk about treatment, because everybody is a little bit different based on what their root cause is. But absolutely, the number one place that I'm going to go is going to be, what are you putting in your body, as far as the diet goes.
Hmm.
Yeah.
Thank you. That's helpful.
Yeah.
Okay. Any other questions for Dr. Carlson here?
I just have one. How much impact does iron supplements have in causing iron overload?
You know what? Like gosh, I don't personally see that a lot, but I mean, you might have more of a better answer to that than me, because imagine the person, the woman that at one point in time was told that she's iron deficient, and she wants to be a good patient, and she wants to take care of her health, and so she's just going to take iron supplements, and then we don't have routine iron testing, and so next thing you know, 10 years later,
She's overloaded. Yeah.
she's overloaded. I don't really see that a lot in my practice, but you probably do in your patient population a little more, maybe.
Yeah, well, the thing is too, is that a lot of them are anemic because of their kidney function.
Right.
Sure.
Right.
And so what did the doctor say? Oh, take iron. So you have these little old ladies taking iron, and their kidneys, they're overloading themselves, and we see that, and their anemia is not getting any better because it's due to their poor kidney function.
Absolutely. Yeah, I generally think that if you are a non-menstruating, non-reproductive age woman, you really don't need to be on iron. And if you are, there's a thing we need to be looking at. Like I do, physiologically, that doesn't make sense to me.
Well, I think they should when they do studies on the geriatric population and their anemia, a lot of it is due to, yes, medication.
Okay.
And
That makes sense. That makes sense. Yeah. Yeah.
Okay. Well, the hour has arrived here. Angela, you've given me back the screen automatically. Good. I appreciate that. And what I'd like to do is let's just take a look at what's coming up next week. Loya Riggin, permanently transform your weight by identifying and eliminating subconscious obstacles. Very good. Loya, do you want to give us just a thumbnail sketch of what you're going to be talking about?
Yes, well, I'm going to be speaking about just our subconscious blocks that we have to weight loss. I think that a lot of time when people spend a lot of money and time and energy on what they're eating, different diet programs, they can only seem to lose a few pounds, and then they tend to gain it right back and gain even more back. A lot of times there's a subconscious block, and that could be from several things. It could be from childhood trauma and believing that the weight is a protectant for you somewhere in your subconscious mind. And so we'll just identify some of the ways that we have obstacles for ourselves, our self-sabotage. There's also self-sabotage. And not only will we identify, but we'll talk a little bit about how to take care of that. Remove those blocks.
Very good. Wow, that's going to be powerful.